cure to cure. This is your day.
Every 17 seconds, someone is diagnosed with diabetes.
Since 1991, Tour to Cure and Step Out's fundraising efforts have supported advancements in diabetes research, provided education programming, and ensured that we can advocate for the more than 34 million Americans living with diabetes. Because of your support, we have accomplished so much together in the past 30 years, starting with the first diabetes cost reduction bill in Wisconsin in 1991. Since then, we've been able to pass similar bills in 45 states. We continued to ride and walk through the 90s, earning more advocacy wins along the way. In 1999, Virginia was the first state to pass the Safe at School bill to help make sure students receive proper diabetes care and are safe at school. Fast forward to the 2000s. As our events grew, so did our milestones. Starting with a bill in 2003, we supported bills throughout the 2000s that brought an end to discrimination against insulin-dependent commercial drivers and pilots. In 2013, we launched Pathway to Stop Diabetes, a bold, innovative initiative to find a new generation of brilliant scientists at the peak of their creativity. Then, provide them with the freedom, autonomy, and financial and professional resources to set them on the road to breakthrough discoveries. Then in 2018, we launched our Diabetes Food Hub, an online nutrition platform with recipes helping people with diabetes form healthier eating plans. And while these are just some of the milestones, each of them would not be possible without you. In fact, because of you and the millions of participants, sponsors, and volunteers, we've been able to raise over $500 million through Tour to Cure or Step Out since 1991. So thank you for your support through the years, and now we set our eyes on the future, with a goal to participate by standing, walking, and riding side by side as we stay vigorous in our fight to achieve our vision of a life free of diabetes and all its burdens.
We are connected for life.
Hello, everybody, and welcome to the 2021 Texas State of Diabetes Virtual Lunch Series, Day 5. Please do say hello in the comment section below and let us know where you are and where you're joining from. In today's live webinar, we will be discussing diversity in diabetes research. My name is David Lopez, Executive Director of the American Diabetes Association here in Houston, Texas. And our intent today is to bring together industry leaders, healthcare providers, innovative technology creators, and community members from across the state to share insights and find solutions to help people living with diabetes thrive. Panel discussions aim to affect positive change in health for people living with diabetes and their families, and in the underserved communities that they live. Together, we will address, explore, and inspire innovative solutions and resources that can be used to engage the community in diabetes management, prevention, and overall health and wellness. A special thank you to our sponsors, Humana and the McGovern Medical School at UT Health, the Department of OBGYN. Now I would like to introduce a special message from Dr. Bob Cabe, Chief Scientific and Medical Officer for the American Diabetes Association.
Hello, everyone. Welcome to the virtual State of Diabetes 2021. My name is Bob Cabe. I'm the Chief Scientific and Medical Officer for the American Diabetes Association, sometimes known as Dr. Bob. And it is my pleasure to welcome you to our program today. Diabetes continues to be an incredible public health problem. Literally, there are 34 million people with diabetes, 88 million people with prediabetes. The vast majority of them don't even know they have prediabetes. Most of the diabetes in the US is type 2, something like 90%. And so why do we care so much about diabetes? Because it continues to be the leading cause of blindness, kidney failure, amputations, heart disease, stroke, so many devastating complications that can occur from the disease. The good news is that we can do something about all that, and that's why we're here today. The State of Diabetes aims to bring positive change, to educate us all, to share ideas, to problem solve, to figure out how do we make a dent in diabetes together. So, we've come to realize that to really solve the problems around diabetes, no one organization is going to do that alone. It's really going to be working together. Together, we can tackle this issue. So the state of diabetes is centered around the work we're doing at the American Diabetes Association around health equity. Why health equity? Well, the pandemic has shown a bright light on the incredible health disparities that exist in our society. And in many ways, diabetes is the poster child for that. Black Americans are twice as likely to develop diabetes. Black Americans are 3 times as likely to have an amputation. People of color are more likely to live in poverty, and poverty leads to significantly worse diabetes outcomes. So our State of Diabetes program is centered around our 5 pillars. What are those 5 pillars that we think if we address, we can deal with the health inequities that exist? The first one is cure, care, then cost, cuisine, and connect. And you'll hear these topics talked about during our State of Diabetes program. So thank you for joining this program. We hope you come away with not only greater knowledge, but passion to make a difference, to work together to improve the lives of those living with diabetes. Thank you.
Thank you, Dr. Bob. And once again, thanks to our sponsors, Humana and the McGovern Medical School at UT Health, the Department of OBGYN, for underwriting the 2021 Texas State of Diabetes Virtual Lunch Series. We love engaging in an interactive exchange, so if you have a question or a comment anytime during the session, please enter it in the live chat section, and we will answer as many of those as we can. Also, we're just like everybody else. We love being loved, so do push the like button and cheer us on. Joining us today as our panel moderator is Joy Cornthwaite, registered dietitian manager and certified diabetes care and education specialist at the McGovern Medical School at UT Health. Hello, Joy. Thanks for joining us
David.
today.
Thank you for having us, and thanks for that wonderful introduction. So I want to echo David's words and encourage our viewers to send questions and messages to us to support the panelists in the chat below. Let's practice now by starting with giving us your location and some hellos and some cheers for our panelists while I welcome them. First, I have Dr. Michal Bartal. She is an assistant professor, physician, maternal fetal medicine specialist, and a diabetes researcher at McGovern Medical School at UT Health. She's McGovern Medical Med School is one of our sponsors for this series. And Dr. Bartal specializes in high-risk pregnancies and and she cares directly for mothers living with diabetes during pregnancy. So thank you and welcome, Dr. Bartal.
Thank you for inviting me. I'm excited to be here.
I'm great. It's a pleasure to have you. And next on our panel is Jennifer Cabe. She is our health literacy expert. She works in health communications as a practitioner, as a professor, and as a consultant. She helped to define the field of health literacy during her work at the Office of the U.S. Surgeon General and has more recently focused on advancing health literacy as a means of improving health equity, inclusion in life sciences research and development. She earned her bachelor's degree in communication at Trinity University right here in Texas, and her master's in public communication with an emphasis in health communications at American University. So welcome to you as well, Jennifer. Thank you for being here.
Thank you, Joy, and good to see you, Michal. I'm so excited about the conversation we're going to have today, and it's always great to be somewhat back in the great state of Texas and with friends. So thank you.
So, Dr. I'm calling you Michal, Bartal altogether. Michal, can you just begin with telling us a little bit about some of your research, and that'll start us off.
Yes, of course. Thank you for the opportunity. So, as Joyce said, I'm a maternal fetal medicine specialist, and I did my fellowship here in Houston in UT Health. And as part of my fellowship, my desire was to improve care for pregnant moms with diabetes during pregnancy. And one of the opportunities was to do a clinical trial actually looking at different types of insulins for pregnant women with type 2 diabetes. So I was fortunate to have the help of Joy and the other team in the center. And we did a randomized control study actually comparing two types of insulin, the newer insulin analogs versus NPH for pregnant women with type 2 diabetes. We finished that trial last year, and we were able to publish it in the AJOG journal. And I feel that was an opportunity to actually take care of pregnant women. That's always a window for us of opportunities when patients actually take care of themselves, not only to reduce neonatal complication, but also to reduce maternal complications as well.
Mm-hmm. And how is that an example of diversity and inclusion? Do a lot of studies look at pregnant women living with diabetes?
Yeah, I think that's a great question. So first of all, I think a lot of the researchers are afraid from pregnancy. So in general, pregnancies a lot of the times, especially with, medication wise, is an exclusion criteria. But I feel that pregnancy is actually an opportunity for us to improve care for moms in general, and not only for the pregnancy, but also for their future life. The other point is that a lot of the times patients that we take care of during pregnancy, the patients that we take care of are actually more involved in their care. They're more engaged. So including them would help also to improve their care later in life and not only in pregnancy. The other point is that we are able, with doing research during pregnancy, to include diversity of population and actually see if one type of population responds better to one type of medication or not, and letting them be part of that research in order for us to really know which type of medication works best for one type of population versus the other. I think the advantage of doing that in Texas and Houston is that we have diversity of population to actually see if their outcome is improved from our current intervention compared to studies from Europe or studies from outside the US that actually have different population. It's a different diabetes, different social determinants of health that are also important to include in our research.
Mm-hmm. And Jennifer, in your opinion, how do we identify these things like Dr. Bartal is saying? How do we identify how to make and whether or not a research effort is inclusive?
So, Joy, that's a great question. And Michal has just said so many important things. I hardly know where to begin, but I'm going to focus on just a couple. One is she's mentioning that there are people who are frequently excluded from research for a variety of reasons that are what has led to a great deal of and caused a great deal of the health inequities that we experience across the United States. So she mentioned, just as one example, that it is unusual, and this was with your prompting, it is unusual for people who are pregnant to be included in research. It's also unusual for people who are experiencing a multitude of conditions, what we call experiencing comorbidities, to be included in research. It's also unusual for people with a wide range of physical and developmental disabilities to be included in research. And then when we look just specifically at race, more than 75% of people in the United States who participate as what researchers sometimes call the subjects, I hate that word, but the participants in research are white. So that is perhaps one of the greatest reasons why we don't know as much as we should about how people are going to respond to a variety of interventions, therapeutics like medicine, as well as other interventions around the 5 pillars, the 5 C's that we talk about with the ADA, whether it's cure, care, cost, cuisine, or connect. Those aren't studied enough when it comes to people of color. And that's one of the things that we can address first. And as was already mentioned by Dr. Bob, the pandemic really brought a lot of those inequities to light that have to do with lack of diversity and inclusion in all sorts of research. One other little mention, just another number I'll share, is that it's not only the United States that primarily includes white people in research. In other parts of the world, it's also 65% of participants in research are white. So this really is a global problem and applies not only to diabetes research, but to all types of research that involves people, medical research.
Mm-hmm. And so I love everything that you summarized and provided for our viewers out there. So what comes to mind now for me is, if our viewers are thinking about this, and some of them may be researchers, some of them are people living with diabetes or people who love people living with diabetes, how do we even begin to develop and to think about what should we be doing to change the face of research? What are some preliminary steps that perhaps Dr. Bartal took during her study that you would suggest, Jennifer? What are the first steps to, and there are many of them, I know, but what would be like something tangible and actionable that someone can do?
If I can add to that, I think the most important step is to the way you design your studies. And I think just designing a study is, like, for example, the study that we did took more than a year. And I think one important step is that a lot of people, when they design a study, try to do it, as clean as possible. So they would, really find their outcome in a certain way. But I think the most important step is actually including as much of different types of persons into your study, and not excluding those that don't have, access to care, that might have some social limitations, patients that are, less, frequent visitors to the doctors, all of those, because if we'll include all of those in our study, we can actually make it more generalizable to the entire population for our results. For example, studies that are done outside of the US, were in places that have public insurance, access to care, people that don't pay for their medication so much, cannot be relevant here, because we need to do studies here that will include patients with their limitations, studies with patients from different race, studies for patients that don't have access to care, those that did not have care, for example, from my field, prior to pregnancy, and usually go into pregnancy uncontrolled, will for sure have different outcomes compared to patients that take care of themselves their entire life and then had a pregnancy on that way. So I think including all those people in our study design and our preparation is actually a very important factor that needs to be done doing design of the study, and thinking about all of our different outcomes, looking at all of those, not only on, health outcomes, but also on social outcomes. that are related to that.
Yeah. Because as Jennifer said before, she mentioned the list of people who are usually not included in a study, people with comorbidities. Those are the people that we care for. And it's very difficult to, have a clinical day where someone comes in and they have no clinical comorbidities whatsoever. And so if we're to find interventions and modifications and personalized care, then we really do need to study it in real life.
Mm-hmm. That's true. And one thing I would add, in complete agreement with what Dr. Bartal just mentioned, in terms of the importance of the design of the study, is then after the study is designed, and it can absolutely take many months or even many years to design a study, very important to include in there that we very much want to recruit participants. We want to include people who aren't typically part of studies. And she mentioned all of the reasons why people aren't generally included in studies. And a lot of those have to do with reasons of finance and of location. So there's a lot of talk right now, appropriately, about decentralizing clinical trials. And that's a bit of what we're talking about here in the design of clinical trials. But then even when you get beyond the design and you get beyond what's called decentralizing trials, which essentially means that so many trials are held in places where people have more access to care. Part of that means being outside of the United States. There are very many limitations to care in the United States because of our healthcare system. But if you're in the United States, it's more likely that you're going to be in a clinical trial, be able to participate in a trial, if you happen to live someplace that has better public transportation, has easier access to get you to care, and also if you happen to not be a person of color, and if you happen to be able to take off work or have appropriate childcare while you go and participate in a trial. But the next part, after you've done all the work of the good design and you've really made every attempt to decentralize your trial, is really about making the appropriate outreach through appropriate health literate communications to potential study participants, to whole populations of people, to encourage them to participate in the trial. And that's very easy to say. I just said it. There we go. Okay, let's do that. Sounds good, right? Thumbs up. It's very difficult in practice to convince people who have looked back on what their family members have experienced now and in the past, and the way that they have been horribly treated in research. And those experiences aren't 100 years ago. They're just one generation or two generations before the experience, the life of the person whom we're trying to recruit. So when we talk about recruiting people, we're talking about having to start at a baseline of building trust, of showing respect, of showing that this is a safe place where you're going to come and you're going to be cared for. And that is fundamental. That is what we would call sort of table stakes to get people to participate in clinical trials, is trust and respect. And that's something, obviously, that Dr. Bartal and her colleagues were able to accomplish, to do the research she talked about just a few minutes ago at the beginning of this conversation. But it can't be emphasized enough that that is extremely difficult and not the norm. And she should be commended for that and should continue doing it and have all the opportunities toward funding that she needs to do it. It's essential work.
Thank you, Jennifer. That's a great that's a great comment, and I appreciate that very much. I feel like Joy and I have struggled through that, because it's exactly like you said. It's being I think the research needs to be done by clinicians, that are involved in patients' care, that see the outcomes, that are involved in, that get the trust from the patients to be included in those trials. And we can state, both of us, with the insulin trial and another trial that we're currently doing about continuous glucose monitoring for pregnant patients. We are seeing that when we are approaching patients about studies, talking with them, they already know us, they trust us, they're part of our care. And of course, that our enrollment rate increases and patients feel like they're in a good place because we can, really explain what's going on to them, because we are part of what's going on in their pregnancy, and they trust us. So I think being a clinician and seeing those patients every day helps you to think about ideas for trial, but also to do those trials. And one of the greatest limitation, as for all research, is time and funding, of course, in order to help us change outcomes for those patients with diabetes.
Yeah. And I love that you both just touched upon one of the questions that I was actually going to ask you, which was, how can researchers overcome the historical injustices that can sometimes influence the participant hesitancy to be a part of the study? And I think that trust building and that respect is very, is at the top. It is what starts off the conversation. It's what allows you to say, may I ask you this question? May I ask you to participate? And then allows them to hear and listen to what you're asking. I also think we had talked about this a little bit off screen before. It's participant buy-in, right? That's one step too, to improving diversity in research, is to have someone know that what is being looked at, the question that we're asking and that we're trying to get to answers in our research, is relevant to them. How important is that, do you think? And that's a question for both of you.
Mm-hmm.
From my experience, I think it's important to them, but I was surprised for how many patients we have that are actually, when you tell them, this trial is to look at different type of questions and to look at an intervention, whether it's going to be helpful or not. And I'm not sure it's going to be beneficial specifically to that patient, but a lot of our patients, and I'm surprised even in pregnancy, when I tell them, this is for future pregnancies, so we might be better. We might take better care of our patients. We might find a better way to diagnose diabetes in pregnancy. A lot of them are very engaged. And just by saying that, they are like, oh, wow, yes, if I can make a difference, I would love to. Of course, there are questions and they always want to know, if there's risk involved. But a lot of the patients that are participated in our studies, and Joy, I think you would agree with me, are actually wanting to participate in order to improve care, even in the future. They don't really necessarily are interested in their current pregnancy. They are actually involved and they want to improve future care for patients with diabetes, maybe because they know the disease, maybe because they want to make a difference as well, similar to us.
Yeah, one of the things that we do find when we study and ask trial participants why they participated is what's sometimes just called altruism. They want to help. They want to pay it forward. Another thing that I would add, after just agreeing with everything that Michal just said, is that the research, sometimes when we can explain to participants that the findings of the research may not only help future pregnancies, future people with diabetes, but also in a clinical sense, of course, which is what Dr. Bartal is referring to, I'm sure, in great part, but also in the ways that have to do with the other parts of the life, because a person with diabetes is not only experiencing, as we all know, a health condition, a clinical condition, and outcomes to that, but they're also experiencing a lot of other things in their life, whether it's in financial or in relationships or in the way that their time is spent. And one of the things that is actually quite effective in talking with people to help them to understand the value of their participation in a clinical trial, particularly if they are somebody who's not, they are part of a group who's not usually represented in a clinical trial, say somebody who's a person of color who has multiple comorbidities, or maybe is living in a rural area, all the sorts of folks we've previously discussed, is to also explain that when the results of these studies become known, once we get to the end of the study, and maybe it's published in something as important as what Dr. Bartal mentioned, the American Journal of, was it Gynecology? American Journal of Gynecology?
Obstetrics and Gynecology.
Obstetrics and Gynecology. Or maybe it's a white paper that is published. But the data get out there and then are used by people who are making policy decisions, making decisions that have to do with how reimbursements occur for patients, that have to do with all sorts of things that can affect the social determinants of health. And from having, as was mentioned when you introduced me, Joy, having worked in government, I know that there are, as I was a mid-level bureaucrat who was looking for the data to be able to show my bosses and to be able to show the people who can make those changes in regulations and in policies and in legislation. But the good intentions of people who want to make those changes because they understand the many challenges that people with diabetes are experiencing that have, of course, to do with the clinical aspect, but also with all the other parts of life. We need the data to make the changes, and that can be another way to help people to decide to participate in a clinical trial is, if we can get this information, we can actually make change to society in 5 years. It might take 10 years, but we have to get the data to get us there.
Mm-hmm. And I think that's an important part of our enrollment process. So I'm glad that you're saying we're doing it right.
Good.
Yeah.
And
I think it's
also so well, Joy, but good.
One of the major things with research is publishing, and I think one of the major things that need to be included in the government decisions or public health decision is our table 1, as we call it, which is including all the maternal or baseline characteristics. Because when you look at studies, you need to include all of those: the age of the patients, their race and ethnicity, what type of insurance they have, what type of education they have. And actually, decision needs to be made by those results that of a trial that's actually including patients that are similar to that population. Because our trial that was that found that insulin analogs are better than NPH maybe have been negative in a population and outside of the US, just because of the difference in those maternal characteristics. So when making those decisions about social health, about economics, about insurance and all of that, we should include what type of population was studied. And that is why those, we need to include as much as patients as possible, so it would be applicable for our population.
Yeah. And so, Michal, you bring up a pretty important point, right? So in that table 1, as someone who's reading table 1 and looking and thinking, well, this study says that this wasn't effective, so perhaps I don't need to make this into clinical practice. Perhaps I don't have to use this to guide policy change, say in which medications we choose during pregnancy. How do we get at improving the health literacy of the people who are consuming the information and looking at the outcomes of studies that are important like this one?
Yeah, that's a great question, because I think a lot of the data is driven by our guidelines a lot of the time, that include a lot of studies that are actually not including the US population. So, for example, for diabetes and pregnancy, a lot of the studies are actually coming from Europe. Which is a population that has access to care, more access to care, different race, BMI completely different. So I think, and our guidelines are based on that. So I think it's our aim to educate more care providers about the findings that we have with studies here that might be, even might be smaller because of, the population. They might include different outcomes, but they are more relevant for the people that they take care of. And I think educating our healthcare providers about those results is part of our care, and should be part of our aim for research. For example, a study that we're doing now about continuous glucose monitoring versus regular monitoring would probably be negative in Europe because those patients don't have problem going to the doctor. They can come every week. They don't have struggles with missing work as much as the US population has. That the benefit of having remote blood sugars, that they don't need to actually come in every week, that we can see their sugars, will probably be more beneficial here than in a different population that is struggling less with healthcare. So I think taking all of this into account should be part of our health literacy and part of our information to doctors that are taking care of those patients. And that is hard because when people are used to use one type of insulin, it would take them years to change their mind because this is their practice. So part of this is us educating them about our results and publishing it in journals that have good review and good care, good access to healthcare professionals.
And I would just add there, in terms of answering your question, Joy, that if we look at the continuum of health literacy that you and I have studied together, that it's about information, right? But it's it applies equally whether somebody is a patient, whether they're a clinician, whether they're a policymaker or government official making decisions. We have to have help finding information. That's the beginning. And oftentimes these days it's the internet. Sure, we can find all sorts of information. But then the next step is, can we understand the information? And then we go on from there. There are 3 more steps still. And the next one is, after we understand the information, can we evaluate it in the context of the life we are living, whether we're a patient or a clinician or anybody else who needs to be convinced by the outcomes of the research to make a change. But even after evaluating, there's this big, long phase of communicating about what we have learned, about the information. We want to talk about it with others. We want to send texts and write emails and post online. And we, in particular, want to talk with people we trust. So as Michal was saying, it's other clinicians. People are convinced by reading things in journals or by talking with other clinicians who they trust. And it's only after all those 4 steps that we get to behavior change, or what in health literacy we call using the information to make an informed decision about something related to health. And it's a long process that requires a lot of back and forth often for people to make changes. So Michal, to your point of it's a big deal. It can take years to get somebody to change from one type of insulin to another, and all of the different inputs that it takes to get them to make that change. And sometimes the inputs are from a standpoint that isn't even clinical. It has to do with, like you said, economics and access. But it's a long process along that continuum usually to get to change. And that's what is something we all need to, I think, accept better, is how much time and energy and resources it takes when we're dealing with such a complex issue as not only research, but also the complex issue of living with diabetes.
And so just thinking of all of these things together and sort of summarizing it in my own mind and wanting to evaluate it and use it, all of the wonderful things that you all said today. I think that for our viewers watching, I think to begin with an understanding and a recognition that the development of a plan for your research and a design plan for your research is important as the research itself. And then I think something that sometimes we don't get to do as much because, we're working or we have a new project, is that health literacy component, Jennifer, where we aren't taking the time to maybe help others to understand the information and then to evaluate it and then to communicate it over and over again so that they can impact behavior change. Because I think that sometimes we publish and then that's it. So what are we going to do with this information? What are we going to do with this these valuable insights, and how do we make those interventions available to the people who need them, to people living with diabetes?
Michal, did you want to go first, or shall I?
You can go first. I can add something at the end.
Yeah. So, in summary, you did a great job summarizing, Joyce. I'm not exactly sure what I'm going to add, but I would say that in summary, what we have to make an essential part of any research outcome is ensuring that the information, the findings in the scientific terminology, get to the people who need to change something that they can change in the context of their lives. So whether they're a policymaker, a clinician, a patient, a loved one of a patient, somebody running a nonprofit organization, somebody running a clinical setting. There's so many different inputs into the life of somebody with diabetes. People deciding what bus routes are going to be the ones that people can access most easily. But that's the key part of, once we have the great design of the research. Well, let me back up. First, we have to have the funding. Then we have great researchers, a great design of research, and then we recruit people into the types of research that needs to occur. We do the research, we have great methodology, we have active participation, we meet all the marks, we have metrics that make sense for the actual condition that we're looking at. That's something that is sometimes missing, that we don't have. We don't look at the right metrics. Michal touched on this a bit. Maybe we've got the number of people who want to participate in the trial, but my goodness, none of them is a person of color. That can literally happen. I have been excluded, kicked out of clinical trials a couple of times for not being white because of my ancestry. That is something that still happens today, and we have to stop that. We have to say that part of our metrics are to include, to have diversity of the participants. And then once we have done the research and we have the findings and we publish, it's just exactly like you touched on, Joy, that we have to find ways to communicate the findings, the key outcomes to the people who need that information. And that's a communications endeavor, and is something that we're getting better at from a clinical and research standpoint, we have people like Dr. Bartal who can talk with non-clinical folks, non-scientists, in ways that folks can understand. It's not all, 10-syllable words that most people say, what is she talking about? That's really important to have clinicians who are health literate. It's not only patients who we say, oh, you need better health literacy. That's something that used to be a real kind of negative way of looking at health literacy. We all need to improve our health literacy, and that includes clinicians. So somebody like Michal, being able to talk about her research is an absolute gem, especially that she's a clinician and she's talking with patients and other clinicians.
Thank you, Jennifer. I think you all summarized it really well. And I think the only thing that I would add is that ideally, I think a study should not be sterile. So we shouldn't clean the study. We should actually include those that actually didn't take the medication as prescribed, didn't show up to their doctor's appointment because they couldn't miss work.
Right.
Didn't deliver on time for my population because they were so uncontrolled. All of those should be included in order for us to really look at the real environment and the real people that we're taking care of in order to see if those interventions are helpful for that population.
Mm-hmm. And what did you call it, Jennifer? You called it, I think, real life experience-based studies.
Well, that's actually a fascinating new area of research, real world experience that occurs, after the clinical trials are done and maybe a therapeutic is shown to be effective and it's approved from a regulatory standpoint and it's out in the world and people are taking it. One of the things that we're learning is that by looking at the real world experience of those patients, of those people, we're all people. Sometimes we're patients, but we're always people, right?
People.
That we learn so much more, and that's exactly what Dr. Bartal is getting at in saying that we have to look at the real world experience of being a person with diabetes, being a person with diabetes who is pregnant, being a person with diabetes who that pregnancy is very affected by the diabetes. That's real world. And that is a newish area of research that is one that has really embraced the principles of health literacy, because the principles of health literacy are alive and well in the real world with the challenges that we face as social determinants and all of the other challenges, particularly in living with diabetes.
Excellent. And is there anything that that either of you wanted to add that we haven't covered? I think we've covered so much really fantastic things, and I know that as like a junior researcher who wants to make the world a better place, this has been fantastic for me, even just to think about the different things that we do with our participants that are good, and then also to reveal some of the things that we can do a little bit better, because we can all improve some way, somehow. Is there anything else that you think we've missed?
I think we covered pretty much it. I learned a lot from this discussion as well, and I appreciate the opportunity to be here. I think, every time that I talk with Joy, we come up with a different research idea and create more, more work, as we are always talking, and more things that we want to, change in our care. So I think always being involved in research is not, and not to be, disconnected from your clinical settings, as to do clinical and research. I think it's one of the ways to improve care, not only for patients with diabetes, but for our discussion here for patients with diabetes. And for me, I feel like pregnancy is an opportunity for us to do that research and actually look at longer term outcomes, because when patients are pregnant, it's a lot of the time it's the only time that they're actually taking care of themselves because they're worried about the baby. So this is, I feel like, doing research for that population is not only for that outcome, it's also for like improving care in general for patients with diabetes.
Mm-hmm.
I think that curiosity, I think that curiosity keeps you open to people's experiences and allows you to recognize that there are experiences that you may not know about, because these are lived experiences of the people for whom we care. And so I think research allows you to have that continued curiosity. That's just my piece.
Well, I'm clearly biased. I'm here in a conversation about diversity and inclusion in research, but I would absolutely agree with both of you that every clinician can improve their approach to being a clinician by participating in research in some way, whether they contribute to a methodology or they're actually the PI or they are whatever it is that you're doing. It's a continuous sort of virtuous cycle of asking questions leads to some answers, but also more questions. And that is really the way to be the best possible person, as well as clinician, when it comes to helping people who maybe have been marginalized in their care, have certainly been marginalized in research, in clinical research. But that's it's also a way to be living a more fulfilling life as a clinician and as a person, is to be in that mode of curiosity that we get to be in when we're figuring out what are the best questions that we can ask. What questions can we ask the data that we've received from a clinical trial? And those questions aren't just, I'd kind of like to know. It's because we have so much to do to improve the health and the lives of people living with chronic conditions, and including diabetes. There's so much to be done. So let's get in there. Let's ask the right questions. Let's advocate for the funding to do the research. And then let's make sure that once we have the findings, we communicate it. Even after we're tired of communicating it, there's still a lot of people who haven't heard it, who need to make more informed decisions about their health and about the health of entire nations. So it's never get tired of asking the questions and communicating the answers.
Excellent. I think that is a wonderful way to end. And I am just so honored that both of you said yes and came to share your expertise with us today, because I know you're very, very busy. And so I want to thank you both again, and everyone out there who's watching and joining us. And special thanks again to our sponsors, Humana, and the home place for Dr. Bartal and myself, McGovern Medical School at UT Health, the Department of OB-GYN. While this session marks the conclusion of the live 2021 State of Diabetes virtual lunch series, these sessions will live on as reference at the ADA site. So please share the link, watch again, be inspired to continue all the work that you all do. And as we continue to celebrate Diabetes Awareness Month, be safe, be well, and stay connected.
Thank you.
Inequity isn't invisible. To see it, all you have to do is be willing to look. Education, housing, income, and access to healthcare are underfunded and undermined for people of color and others who are underserved. The result? Systemic health inequity. In fact, a cynic might note that wealth equals health. Look no further than diabetes. It increases the risk for other serious illnesses, including dying from COVID-19. Diabetes is the bellwether not just for the health of our communities, but also for the health of our healthcare system and the health of our society. The inequity causing diabetes isn't invisible. the burden isn't shared. From those who are most likely to live with diabetes to those most likely to suffer complications, and the Americans most likely to die from it. Confronting the reality of diabetes is confronting the reality of health inequity in America. Inaction is no longer an option. Health equity is a right, not a privilege, no matter your race, income, zip code, age, or gender. It's time to demand health equity now.